Hello, this is Dr. Grant Cooper from Princeton Spine and Joint Center. What I'd like to do with this video is talk to you about facet joint pain, and specifically how you go about diagnosing facet joint pain, because it's an area where there's often a lot of confusion, and it's very important if you're dealing with facet joint pain. So what I'd like to say at the outset is that if you have facet joint pain, or if you and your doctor are thinking that you might have it and you're curious about it, then I think this is going to be a very valuable discussion we're about to have. If you don't have facet joint pain, or you're not interested in facet joint pain, then I appreciate you tuning in, but this is going to get pretty into the weeds on facet joints, so this one might not be for you. All right, that said, let's jump into the facet joints. Whether or not you have it in your lower back or neck, we're going to address both of them because the way we go about diagnosing them is actually sort of the same. So the first thing just to mention is when you talk about diagnosing something, often we start with the history, right? The patient will say, when do they experience the pain? What makes it better? What makes it worse? Etc. In the lower back, the facet joints are usually worse when you're standing and leaning backwards because that loads the facet joints, and they usually feel better when you're bending forward and sitting. If you lined up 10 fellowship-trained spine people in a room, we would all say the same thing, that's what we would understand to be true. And at the same time, what we would all have to acknowledge is that whenever we do studies to look at it, we're never able to prove that that actually is the case. And in fact, facet joints can present in lots of different ways. So we can't rely on the history in order to make the diagnosis. But certainly with the lower back, if standing and leaning backward makes the pain worse and bending forward makes the pain better, we start to think facet joint pain. In the neck, facet joint pain looks really identical to disc pain. So the history isn't going to be very helpful in that regard. In the neck, the facet joints are by far the most common cause of chronic neck pain. In the lower back, they are the second most common cause of chronic back pain. So that's good to keep in mind as well. Physical exam, again, in the lower back, if we load the facets by having the person extend backwards and especially to the sides, and that reproduces the pain, that's suggestive of facet joint pain, but it's not diagnostic of it. Similarly, in the neck, if the person leans their head back, extends the neck, and that reproduces it, that could be facet joint, it could be disc. It's not diagnostic of the pain. MRI is going to be the best diagnostic tool in terms of imaging study that we have to look at the facet joints. The good thing is you can see the facet joints really well on MRI. The bad thing is they're not going to be able to make a diagnosis of facet joint pain because there's so much background noise. Basically, so many people have facet joint arthritis. Facet joint arthropathy is the term you'll hear a lot, and don't have any symptoms from it. Even if they're having symptoms from one facet joint, there'll be lots of facet joints that look arthritic and they're not having symptoms from all of them. That's important to keep in mind. And sometimes the facet joint will look great on the MRI. However, the facet joint's still causing the pain. And the reason for that is that you can have micro tears on the inside of the facet joint that you're not going to pick up on an MRI. Now, sometimes you will see, an exception to what I just said is sometimes you will see a large effusion, a lot of swelling, acute swelling in a facet joint on an MRI. It'll really light up. Now that also is not diagnostic of the facet joint, but it certainly is very suggestive that might be what you're dealing with. But still, you can't hang your hat on the MRI findings and say that the facet joint is what's causing the pain. I mean, you can even have stress fractures running through the pars interarticularis, which is right next to the facet joint in the back, and those can be asymptomatic in about 6 to 9% of people who used to play certain sports. They're walking around with those stress fractures and never have any symptoms from it. So the point is you have to take your MRI findings with a grain of salt and treat the person, not the MRI finding per se. So the way we go about diagnosing facet joint pain at long last, right? We're finally getting to the gold standard way, is by injecting it. Really, you use fluoroscopic guidance, using X-ray guidance, to take a needle and put it next to the facet joint. And if you inject the joint and it gets better, then you've found the source of the pain, sort of. And this is where I think it's really important that we dive into the weeds so that we understand this. There's two ways that you can block a facet joint. The way that's most common, especially in America, is we do basically a joint injection, intra-articular injection, like you would with a knee, a hip, a shoulder, a finger. You can take a needle, go under X-ray, and put medicine directly into the joint. And usually what you're injecting when you do this is lidocaine and steroid. The lidocaine is there because we're interested in when the lidocaine is put into the joint, does the pain go away immediately, right? Lidocaine is an anesthetic. So if you get up off the procedure table and you move around and the pain is gone, then that suggests that the facet joint is causing the pain. Because when we blocked it, the pain went away. Now the steroid's there as an anti-inflammatory because we're hoping that the lidocaine will wear off and the steroids will have a chance to kick in. And that usually takes a couple of days to a week, and it crescendos over a couple of weeks. And we're trying to use the steroids to help fix the problem. As the steroids kick in, it serves to take away the inflammation, and then we can use that as a window of opportunity to work on stretching and strengthening the muscles so that hopefully the pain doesn't return as the steroids wear off. But let's come back to the diagnosis. So if you use an intra-articular joint injection, that's a good way to get a sense of, are the facets causing the pain? I say a sense of for a few reasons. Number one, we have to remember there's about a 30% placebo rate. So when you block someone, meaning when you put lidocaine into the facet joint and they get up and the pain is gone, it could still be placebo, right? For one, there's a lot of adrenaline when you get an injection. And for another, placebo is just a very real phenomenon. So we have to be aware of that before we hang our hat on a diagnosis. Now, the other thing when you do an intra-articular facet joint is that a lot of times the capsule of the joint is going to have small holes in it. And so you can have some leaking of the medicine that you put into the facet joint. Some of that, depending on how much volume you use, will leak out of the facet joint and onto the adjacent structures in the back. And so that makes the diagnosis, again, a little bit more messy. The way it's often done in America is you'll do an intra-articular facet joint injection first. If that takes away the pain immediately from the lidocaine, then great. If the steroids don't work, then the question is, okay, well, is the facet joint really the source of pain? And we think that there's probably about a 30% chance that there's not, for the reasons we just mentioned, primarily because of the placebo response. So then you do a repeat injection. But the second time, because you're not trying to fix it at that point because the steroids didn't help in the first injection, you do what's called a medial branch of the dorsal ramus. Basically, you're blocking the sensory nerve that innervates the joint. Again, you're using X-ray guidance, and you're going in with a needle, and you're using a very small amount of lidocaine, of numbing, to just numb the little sensory nerve that goes to the joint, so that, and you're using such a small amount because you don't want the lidocaine to extravasate out into other structures. You want it to stay right at the part that you're testing. If the person gets up, and usually you'll give the patient a pain diary to see how they feel over the next several hours. And what you're looking for is, does the pain go away for a few hours when you put the lidocaine in? If that happens again, so now we have two diagnostic blocks. The first, the facet joint injection, and then we've repeated it weeks later with the medial branch block. And if the pain goes away the second time with the medial branch block, well, now our false positive rate drops down to about 8%. So we have about a 90% probability that we've got the right spot, that facet joint is really causing the pain. And that's really important because the next step in treating the pain in that instance would be a radiofrequency rhizotomy, where we're taking another needle and we're going back to that same nerve that we blocked in the second block, the medial branch of the dorsal ramus, the little sensory nerve that's going to the joint. And we're using radiofrequency energy, which is basically an oscillating current that goes back and forth really fast, that generates heat, that then denatures the sensory nerve going to the joint. So basically you're burning the little sensory nerve, so you can't feel the joint anymore. It's like the phone's ringing, but you cut the cord so you can't hear it. So we really want to know that we have the right joint before we go in and we burn it. And that's why we go to such pains to make sure that we're in the right spot. By far the most common reason why the radiofrequency procedure doesn't help people with facet joint pain is either it wasn't done right, or was rushed, but more commonly it's because the diagnosis wasn't appropriately made in the first place, either because only one block was used or no blocks were used, other various reasons. Now, that's the way that facet joints are often diagnosed in America, in the United States. And it's because you're combining the joint injection with the medial, with the block of the sensory nerve, the medial branch of the dorsal ramus. A more proper way to get to the diagnosis is actually using two medial branch blocks. So if you're just purely trying to diagnose the joint, and you don't care about trying to use an intra-articular steroid injection, because you're basically not thinking that you're going to use steroids to try and help fix the pain, but instead you're going to work directly towards the radiofrequency rhizotomy procedure. The way you would go about that is you first do the medial branch block of the dorsal ramus. You first block only the sensory nerve. You block that nerve. The patient gets up, they keep a pain diary for the rest of the day, and then they come back and you do it again, assuming the first one was positive. If the pain goes away the first day, they come back the next day, the next week, whenever, and you block it again. Now, here's the trick. In one of those blocks, you're going to use lidocaine to block the sensory nerve. Now, lidocaine lasts for typically about 4 hours, 4 to 6 hours, let's say. In the other block, you're going to use marcaine, bupivacaine. That's a longer lasting anesthetic than the lidocaine. And what you're looking for when you use these two different anesthetics is that the patient has a shorter acting relief with the shorter acting anesthetic, the lidocaine, and they have a longer acting relief with the marcaine. And you don't tell the patient, right? The patient doesn't know which they've had. They don't know if they were blocked with marcaine or the lidocaine. All they know is that they had an injection. Ideally, the doctor also doesn't know. Ideally, the doctor is blinded to whether or not he or she is injecting lidocaine or marcaine, so that way they don't inadvertently influence the results. But what's most important is that the patient receive at one point lidocaine and one point marcaine, and they keep a pain diary both times. And you want to see that they have longer acting relief with the marcaine and shorter acting relief with the lidocaine. Now, the other thing that we should mention is when we say relief, what we really mean is about 80% pain relief. Right? We're really looking for, do we turn the pain off like a light switch when we block the sensory nerves? We're not looking for nuance of, is it 30% better or 35% or 50 or 55 or 60%? We're looking for, does blocking the sensory nerve make the pain go away? Hard stop, right? It doesn't have to be 100%, but at least 80%. One caveat to that is sometimes what you'll find is that when you block the sensory nerve, you block the joint, one part of the pain goes away completely and one part of the pain stays there. And with that, we're talking geographic regions. So let's say that the top part of the pain is still there, but the bottom part of the pain went away completely. The reason why that's important is because what that tells you is that the facet joint in that instance is only responsible for the bottom part of the pain. So therefore, what you can tell the patient and what you can know is, okay, if we go in and we use the radiofrequency rhizotomy to burn the sensory nerve of the joint, then what we can reasonably expect is the bottom part of the pain is going to go away, but the top part of the pain we still haven't figured out. So we're going to have to return to that to figure out maybe that's coming from the disc, maybe it's coming from something different or a different facet joint level. But from that one from that one joint that we just blocked, what we can say is that's responsible for the lower pain, not the upper pain, because that's what went away when we blocked it. I think I covered everything that I meant to with the diagnosis of facet joint pain. So sometimes what we've found in our office is that we go through great pains to try and understand the diagnostic, to try to explain the diagnostic process, because sometimes people have the diagnostic block and then they're disappointed when a day later the pain returns. But really, it'd be nice if it went away, but that's really what's supposed to happen when you only use lidocaine. because you're only putting in an anesthetic, and we're really doing it to diagnose the problem, because we need an accurate diagnosis so that we know what our real treatment options are. I hope you found this video useful. If you have, please like the video, subscribe to the channel, and please tell a friend who you think might find it useful as well, because that's the best way that we can spread good health information and achieve good health outcomes together. Yeah, as always, if you have any questions or comments, you can reach me at drcooper@princetonsjc.com, or feel free to leave any comments or questions in the comments section here. Thank you very much.